Acute respiratory failure. See, actually, the mechanism or the underlying changes for respiratory failure for both acute and chronic is quite similar. Okay, the term acute is put there if the respiratory failure developed very acutely. So, within hours, within minutes, or within days. And chronic, when the respiratory failure develop over weeks to months and over years. So that is the main difference. Okay, but the underlying changes in the physiology is the same. Okay, so we said that the patients have respiratory failure if there's failure of gas exchange due to inadequate functions of more of one or more of the essential component of a respiratory system. So clinically, respiratory failure is manifest as either hypoxemia, hypercarbia, or a combination of severe hypoxemia and hypercarbia. So the hypoxemia, generally we give a cut of less than 60%, 60 millimeter mercury or Tor, and in for hypercarbia, the normal range of your blood carbon dioxide is for 35 to 45, but for clinically significant hypercarbia, usually it would be more than 50 millimeter mercury. Okay, so what are the five components of the normal integrations of the respiratory system? You have five. These are your nervous system, the musculature, okay, which would be the pump, the airway, the alveolar unit, and the vasculature, okay, which would participate in your gas exchange, not only for gas exchange, also to distribute the oxygen to the periphery of the body. Okay, so sorry. So the controller, the main controller, the autonomic controller is in the medulla. I hope you still remember. So in the medulla, we have your dorsal group of neurons and your ventral group of neurons, and different afferent and efferent neural pathway that would update the autonomic center as to what is happening to the blood gas pH of the body. Okay, so this would trigger an increase in ventilations or a decrease in ventilation. So if your medullary response respiratory group of neurons is affected, okay, there's a CNS conditions that affect this particular part of the nervous system and it is knocked off, then that means you cannot breathe on your own at all. So you have lost the autonomic control of ventilations. So CNS problem, no breathing at all. Okay, musculature, the main function is to for the muscles to create changes in pressure in order to allow air to flow in and out of the lung, and the airway is a circuit wherein the air can flow in and flow out of the lung. So if there is an obstructions in the airway, then there would be a problem with the conduct of air flow through the atmosphere to the lower respiratory tract. So that means there would be inadequate gas for gas exchange. Okay. Alveolar unit is where you have your gas exchange that takes place. Okay. So this consists of your respiratory bronchial, alveolar duct, and your alveoli, and the pulmonary vasculature, which consists of your pulmonary capillary network, pulmonary membrane system, okay, wherein you have your gas exchange from the blood. The blood give off your carbon dioxide, and now and receive oxygen from the alveoli. So that is how the gas exchange takes place. And of course, if there is problem in this blood flow to the alveolar unit, then there would be a change in your a problem with the gas exchange. So let's say sometimes you do not have any blood flow to area of ventilated lung, then that means that ventilation is already wasted. Or you have blood flow to unventilated lung, then the perfusion is also wasted. And this can cause changes in your arterial blood gas. Okay. So if there is changes in any of the five category, then this can lead to the development of the different types of respiratory failure. Your type 1, type 2, type 3, and type 4. Type 1, or also called your acute hypoxic respiratory failure, this occur when there is alveolar flooding. So ARDS is a very good example of your type 1 respiratory failure. And usually the mechanism of hypoxemia is because of shunt. Okay, so what are the different mechanisms? We have already reviewed the different mechanism of hypoxemia. Remember, isn't it? We talked about this a few days back before just before your midterm exam. Still remember? Hello, forget already? Okay. Then your type 2 respiratory failure occurs as a result of alveolar hypoventilations, which and result in the inability for effective eliminations of carbon dioxide. There are several mechanisms wherein your patients would develop a type 2 respiratory failure. One of the mechanisms is impaired central nervous system drive to breathe, like among patients who have drug overdose, brainstem injury, or patients who have this sleep disordered breathing and hypothyroidism. Okay. And the second impairment is among patients who have muscle problem or neuromuscular dysfunction that affects the respiratory system. Example of these diseases would be your patients with myasthenia gravis, Guillain-Barré, ALS, phrenic nerve injury. Okay, so if you have a fall, third mechanism, second mechanism again would be patients who have electrolyte imbalance that causes changes in the muscle strength and fatigue to the muscles because of prolonged problem with breathing due to other causes rather than a primary muscular problem, and patients who have myopathies. Then we can have the third conditions or mechanism wherein there is increased load on the respiratory system, like patients who have prolonged bronchospasm or airway obstructions, or patients who have prolonged decrease in your lung compliance, like patients who have alveolar edema, atelectasis, or atopy. Okay. Or patients with reduced compliance of the chest wall, like patients who have obesity or kyphosis or severe obesity, or patients who have pleural effusion or over distended abdomen. And then, or this can also happen if there is increased minute ventilation requirement, like increased dead space ventilations, patients who are in sepsis, or patients who have pulmonary embolism. So these three mechanisms can lead to type 2 respiratory failure. Type 3 respiratory failure usually occur in the perioperative period. So this is also called your perioperative respiratory failure. The mechanism of the respiratory dysfunction is mainly because of the atelectasis, and the atelectasis occur because of the prolonged supine position of the patient, leading to a decrease in your ventilations and thereby leading to your respiratory failure. Your type 4 respiratory failure is also called your cardiovascular failure because this occur among patients who are in shock. Okay, so because of the decreased perfusion, this can result in the development of respiratory failure. Okay, so that would be the short KD. So how do we now recognize whether the patient's respiratory failure is because of a controller failure, a pump failure, a airway problem, in gas exchange problem, or vasculature problem? So for a controller problem, usually this would affect the respiratory rate, okay, and tendency is that the respiration would be decreased, or if the patient's respiration is increased, it would be very shallow. So this would be a problem of your controller. Okay. And for pump failure, usually the depth of breathing would be very low. And for us, for objective findings, then we can measure for your vital capacity in order to test the amount of air that we are able to inhale. Another way of testing the muscle strength would be your measurement of your maximal inspiratory pressure or your maximal expiratory pressure. For your airway, that's very easy. If you auscultate the chest, you hear wheezes, then you know that the patients have increased airway resistance. And for alveoli, it is also based on auscultations wherein you hear a lot of crackles. But for objective testing that is widely available would be to see a chest x-ray wherein you see the infiltrates. And for pulmonary vasculature, we check on the JVP. And what are the different conditions that may lead to this change specific problem? So for controller problem, this may be secondary to overdose of sedative medications, patients who have severe COPD or interstitial lung disease, toxic overdose, hypothermia post-operatively, or brainstem lesions because of a primary CNS problem. Pump failure would be musculature mostly. There are patients who have myopathy, myositis, or pump paralysis because of toxin or medications such as your aminoglycosides, exposure to your steroids, or your botulism. And for your metabolic disorder that may also affect the function of the muscles, this would be your hypothyroidism, hypophosphatemia, patients with primary neuro problem like your myasthenia gravis or your Guillain-Barré, and your paraneoplastic syndrome that causes your Eaton lumbar syndrome, okay, and your polyradiculopathy of critical illness, usually seen among patients who are admitted in the intensive care unit. And for you to be able to evaluate this, you do your muscle evaluation like your EMG or your NCV. And for myopathies, we have to do with muscle biopsy. Airway, okay, if you have wheezes, so the usual airway obstructive disease would be asthma, COPD, but aside from this, bronchiolitis can also lead to a disease of the airway, as well as mass lesion or stricture of the airway. And for your alveoli, number one, of course, would be pneumonia and pulmonary edema, pulmonary hemorrhage, not common, ARDS, pulmonary contusions, and drug reactions leading to the development of ARDS. Okay, pulmonary vasculature like your pulmonary hypertension or your pulmonary emboli. Okay, for us to diagnose acute pulmonary emboli, you need a VQ scan or a CT scan. And your pulmonary hypertensions, actually, you evaluate the heart to the echo. Okay, I think that's the one. And for alveolar malformations, this may also lead to vascular problem, or AV shunting can lead to this problem. So you can do a 2D echo with your bubble study. Okay, any questions so far? None. Thank you.